Welcome all of you to this live program, The Orthopedic Principles. Today, our guest of honor is Professor Cyril Mauffrey from Denver, United States. Dr. Mauffrey is an orthopedic surgeon specialized in the management of complex trauma and joint replacements. Dr. Mauffrey had an international background, having grown up in Southeast Asia, originally from France. He did his medical school in Italy, orthopedic residency in the United Kingdom, and orthopedic trauma in the US. This unconventional path has provided him with a set of tools that have become essential in today's leadership landscape: adaptability, flexibility, and the ability to tackle challenges with an emphasis on sensitivity, diversity, equity, and inclusion, as well as exposure to many different ways to do many different things, especially in the healthcare environment. Dr. Mauffrey became a professor of orthopedic surgery early on in his career and has had the privilege to lead the Department of Orthopedics at Denver Healthcare Medical Center, which is safety net level 1 trauma center. Dr. Mauffrey leads a team of incredibly competent colleagues, which pushes him every day to be a better surgeon, leader, and more importantly, a better person. His clinical interests lie around fractures of the pelvis and acetabulum, as does his research. With over 220 publications, a good number of book chapters, and 6 textbooks, his focus is helping solve big problems in healthcare with partnership with industry, especially in the realm of digital healthcare and artificial intelligence. So today it's my great honor to introduce you to Professor Cyril Mauffrey from Denver, Colorado, United States. Over to you, Cyril.
Thank you so much for the kind words. I just want to confirm, Hitesh, that you can see my screen and that you can hear my voice before I get embarked. Thank you. So the topic selected today, and I think, can you confirm the duration of how long do I have here, Hitesh?
You can take your time, Cyril. We're all waiting to listen to you.
Okay, so I'll try and stick to about 30 minutes, if that's okay, 20 to 30 minutes, leave some time for questions. But the topic that I selected is associated acetabular fractures. And I wanted to keep things simple because throughout the years of doing this, I have come to realize that the more you know, the less you know. And this really applies particularly to topics as complicated as acetabular fractures. And through these few slides, I would like to share some little nuggets and some piece of information that I took for granted for many years, or rather I thought that I knew, but as a matter of fact, I didn't really know. And it took me time to dig into the basic concepts and finding out exactly kind of what's going on in there, and to be a better surgeon, better clinician fixing those fractures. So as you guys know, acetabular fractures are classified into 2 main groups, the simple and the associated fractures. I'm particularly going to focus on the latter. For those of you who are interested in deepening their knowledge on this topic, I've put this link. This is my website, theorthoacademy.com, where you can see a lot of illustrations. I've spent a lot of time putting those together, but they kind of summarize the X-ray views and when do you need X-ray views for what in around the pelvis and the acetabulum. Bear in mind that this is the first stepping stone into embarking in the fixation of acetabular fracture, because without the knowledge of the fluoroscopy, how to get a good quality X-ray, when is a X-ray adequate, when is it not adequate, is a key starting point to a successful surgery. So if you go on this website, you'll find a PDF with all those views and how to get them. You can see at the bottom left there of the screen some illustration of where the X-ray is positioned in relation to the pelvis and the acetabulum that we're trying to obtain. Here you can see the outlet obturator view and the inlet obturator view. I will not spend too much time talking about these X-rays today, just because this knowledge is totally accessible online, but it definitely is something that requires some practice. So you guys, moving on to the next slide, you guys are all familiar with these drawings taken from AO. You have seen them all. Everyone knows how to draw these, but what puzzles me about these drawings, you can see here a posterior wall and column, a transverse and posterior wall. You can see here a T-shaped acetabular fracture, a posterior hemitransverse, and finally the fifth one of the associated fracture, which is the associated both column. What puzzles me with these drawings is while they are reproducible and understandable, they are showing and highlighting the acetabulum from a place that you really never see from. We're seeing the acetabulum from the outside here, but as you know, the hip joint is here, and when we're fixing those, unless we do large, surgical hip dislocations or large combined surgical approaches, we don't usually see the acetabulum from that face. We see it from either the back when we do a coccolangum or the inner surface when we do a stoppa. And therefore, I think there's a little disconnect between the illustrations that we're seeing in the textbooks and the reality of things here as illustrated, the reality of things in the surgical approaches. The second little piece of information that I want to clarify with you and that I want to talk about and express is those pictures that you have all seen and all heard of when you're reading about acetabular fractures. How do you differentiate on a CT scan a column fracture from a transverse fracture? And the immediate answer from most people is, well, a column fracture is medial to lateral, as seen here on the image on the left, right there, medial to lateral. And a transverse fracture is anterior to posterior on a 2D axial imaging. And while this is an instant response from most, if I was to probe the audience watching here, either live or later, if I was to ask you guys, a transverse fracture, as you guys are aware, is a fracture that is cutting the acetabulum here, right? We're cutting the acetabulum here. Why would a transverse fracture be a line that goes from anterior to posterior when the plane of the fracture is actually medial to lateral? So this is the kind of stuff that I want and I'm hoping to solve here through these talks to kind of give you a framework from which to understand these basic topics. So the transverse and T-type, you can see here, these are the classic drawings. And the way to remember them is you keep rotating the T. Here we have a T that's a vertical facing down. For the transverse, it's just straight, and then the T-type reaches down the vertical stem of the fracture, and that stem can be either anterior, midline, or posterior. Then we have the anterior column, posterior hemitransverse, and you see that this T kind of rotates, and now the stem that used to be vertical in the T-type is now facing posterior. And finally, an associated both column. The difference in the three of them, and particularly the difference in anterior column, posterior hemitransverse, and associated both column, is those green dots. And those green dots represent the constant fragment. And that's a key part of the understanding, because the whole purpose of our surgery is going to be to rebuild all the fragments onto that constant fragment. And in order to be successful at this, one needs to be able to know where is the constant fragment, and is the constant fragment inside or outside of the joint. You can see that for the first and the second family of fractures, T-type and anterior column posterior hemitransverse, the constant fragment contains a piece of the acetabular portion, the articular surface. And therefore, it is much less forgiving. The quality of reduction has to be perfect because we are bringing fragments to a constant fragment that contains articular surface. As you can see from the picture below, this does not occur in the associated both column family because most of the weight-bearing component of the acetabulum is contained into the anterior column piece. You could see that piece here, and there is no joint surface attached to the constant fragment. There are no articular pieces attached to the axial skeleton and therefore the constant fragment in green. So this has implications on the maneuvers you need to do, but also the concept of secondary congruence, which is one that allows you in some rare cases to treat an associated both column fracture non-operatively because the anterior column and the posterior columns are detached from the constant fragment, which does not contain articular surface, which molds around the entire articular surface around the femoral head, using it as a mold. So this is what I was getting at earlier. Look at the this view from the inside. You can see how the format that we're accustomed to, very much so in the textbooks and in the AO textbooks and most of the books on the left, is hard to recognize on the right. But on the right, this is a view from the stopper, from the intrapelvic approach. And it is very, very critical for you guys, and I know that this is being recorded, but for you guys to be able to correlate the two so that when you're intra-pelvis, you are familiar with where is the limit of the constant fragment, which are the fragments that I can push on, and which are those that I can't push on because those fragments are not going to move because they're attached to the constant fragment. So memorize this drawing because and reproduce it as you're preparing for your surgery, because it may be extremely helpful and useful to plan adequately. So this is going back to the drawings that I illustrated earlier. I would challenge the audience, and I don't know that we can ask any poll questions here, but it doesn't really matter because I've done this exercise multiple times. But I would argue that this audience, if the question was, what do you think that this stem, this transverse fracture, forget about the T descending fracture there, just focus on the transverse component. This is a transverse fracture. How many of you think that this fracture would be on a two-dimensional CT scan, the first picture rather than the second? And I can guarantee you that it would be a distribution of around 80 or 90 to 20 or 10 in favor of the illustration in the middle versus the illustration on the right, because that's where the plane cuts. And in fact, this is the wrong answer. A transverse fracture extends on a two-dimensional CT scan from anterior to posterior. And the reason for this are illustrated here in this short video. While the transverse fracture is from lateral to medial in its initial course through the acetabulum, as soon as forgive me here, as soon as the fracture exits, it comes up, and it's now a fracture that is no longer directed from lateral to medial, but it's a fracture that is now directed from caudal to cephalad. So it starts lateral, comes medial, and as soon as it's about to breach the acetabulum, it takes a 90-degree turns and aims up proximal to breach the hip socket. And this is the only reason why you see on a two-dimensional CT scan a fracture that actually extends from anterior to posterior, because that is what that is. Now, you may then come to realize, and this is the whole point of this talk, is that because we're talking about fracture configuration, we have the luxury here, now that we're starting to understand this fracture configuration, we can talk about, or we can deduct, therefore, this may influence my clamp positions for transverse fractures, and this may also influence my fixation strategy, because I now know that I need to have some vectors of forces that go from medial to lateral to correct that fracture that goes from cephalate to caudal. It's a medialized fragment. I need to push it lateral, and therefore my fixation too has to be pertinent to that. On the other hand, the anterior column, or it's the same for posterior column, but we're just going to talk about anterior column, is no longer a fracture that is medial to lateral. It's a fracture that has occurred from a movement of external rotation of the ilium. It's like a tear of the ilium. We're tearing this. The movement is, I am pushing this out. And therefore, this fracture appears here as if it is a medial to lateral fracture line. You could see it there. We're just focusing on that anterior column component. This would be its appearance on a two-dimensional CT scan. And therefore, the reduction maneuver for this fracture are very different than the reduction maneuver of a transverse fracture or a T-type. And so is the fixation strategy, because the vectors of forces are very different. You look at this in a more simple drawing to highlight what I just explained in those videos. On the left, A to P line on the CT scan here. On the right, medial to lateral line. On the left, it's a transverse fracture, A to P orientation, because the fracture goes from cephalate to caudal. And on the right, it goes from medial to lateral. It's an anterior column fracture. There's variations to transverse fractures. When I say transverse, this applies to T-types, particularly because the T-type is a transverse with a vertical stem. So transverse fracture can be transtectal, juxtatectal, or infratectal. The closer to the dome, the worse the outcome and the harder they are to reduce. The worse the outcome because, as you know, the roof arc angle is an angle that determines the exit point of the fracture in relation to a line that is drawn from the center of the femoral head up to the center of the roof. And as this fracture line gets away from this vertical line, the fracture becomes less of an issue in terms of outcomes because it moves away from the weight-bearing portion of the acetabulum. You could see how a fracture that exited right in the top of that dome would be much worse than a fracture that exited kind of in the middle here, like a transverse fracture that would be like this, because the dome in this latter case would still be intact. So as I was expressing earlier, again, we're talking transverse, but it also applies to T-types. It's more the concept of having you understand the differences between a column and then a transverse fracture. But you see the difference in appearance on AP pelvis. We went through that. The appearance on axial CT scan. Therefore, the reduction maneuvers are different. For a transverse fracture, we're going to push from the inside, from the quadrilateral plate, from medial to lateral on an intrapelvic approach, or a young Bluth clamp compressing through the Coco-Langenbeck. For a column fracture, we're going to need to internally rotate that ilium segment, and we're going to have to take it from lateral and push it back medial so that it closes down that medial to lateral fracture line. And then the principle of fixation strategy also applied to how the fracture is. For a transverse fracture, we're going to need some screws that will fix that posterior column component and push it as lateral as we can. So that's the first maneuver, pushing it lateral. then we're going to want to fix it from the top to the bottom to capture that newly reconstructed, finally medialized transverse component. For an anterior column fracture, we want a suprapectineal plate with screws that are fixing this displaced anterior column to something that has not moved, and that could be the posterior column or the constant fragment. So you have options of LC2 screws going through the anterior column, fixing it to the constant fragment, or screws that are fixing the anterior column down to the posterior column. This is what a posterior column looks like. Again, it's the same video, so focus this time just on the posterior column, which is this element here. But you can see when in isolation that this is obviously a fracture that would benefit from a Coca-Langenbeck approach to get it from the back. This is the T-type. We visualized that earlier. I'm not going to show it again. The anterior column, posterior hemitransverse, and I've done these videos because I think they're useful to understand exactly what is going on and why do we classify these as those. You could see here, this is a piece of weight-bearing portion of our acetabulum that still belongs to that constant fragment, that big wing piece. And therefore, if we're going to rebuild that anterior column component to that piece, it better be anatomical. Otherwise, we're going to have a huge step off here. And we may also have a huge step off with a posterior column here. So it's important to remember that this constant fragment here is still attached to a part of the acetabulum. Now, from the inside, from the inside, it is very, very different. You can see that this is our anterior column piece. And again, let's simplify things as we have at the beginning. It is an anterior column because the fracture occurred from an external rotation of that iliac wing. It externally rotated. The fracture line on a 2D CT scan would be medial to lateral here. And then we have a transverse that only breaks the posterior column. It's not a full transverse. This is the anterior part is an anterior column. The posterior part is a transverse fracture. So we're going to have medialization of this posterior column component. And therefore, the reduction strategy here from the intrapelvis approach is to push this posterior column back lateral under the constant fragment and to try and fix that and to commit for it to stay there, either with a small plate or with a clamp. But that is a reduction maneuver and the fixation strategy for an anterior column posterior hemitransverse fracture. You can see from the associated both column, which is a final category, that the constant fragment, that is right here where that K-wire is sticking out. And by the way, this view is the obturator oblique view with the ominous sign of this is the classic radiological sign of the spur sign, where it's not a lateralization of the iliac wing, the constant fragment. It's everything else is medialized in relation to the constant fragment and gives this appearance of a spur, which is from that constant fragment. But it's not lateralization. You don't want to push on this spur. You want to pull on the entire acetabulum to lateralize it back to where it belongs. But another important aspect of this is that there is no articular surface attached to the constant fragment here. All of the dome is attached to the anterior column piece. And therefore, we essentially have two fragments that are totally detached from one another, free floating, and that can mold around the femoral head, which this is called secondary congruence. And therefore, some of these fractures in very elderly and sick patients can be treated non-operatively for that particular reason. But this is what it looks like. The steps of this procedure are fairly predictable because we're essentially reconstructing that anterior column piece to the constant fragment and then back to the So anterior column piece to the constant fragment, and posterior column piece to the constant fragment, and then connecting back the anterior column to the posterior column. These are the landmarks of the AP radiographs, and I don't really think that they are necessarily pertinent to this talk, but the first step is understanding the x-rays, and you've seen that at the beginning, the fluoroscopy. The second step is understanding the configuration of these fractures on a three-dimensional model. And then the third step is being able to classify those fractures. And that is where this comes into play, is understanding what those lines are. These are images from the Letournel book, who essentially took some lead wires and placed them, glued them on a pelvic model to understand what lines were what. The reason why I've put those in the slides is that when we talk about the ilioinguinal and ilioischial lines, they're not necessarily lines. In fact, this divot in the posterior column is what is represented by the ilioischial line. So it's not necessarily a line, it's more of a surface area around the posterior column that determines what we see on a two-dimensional image. Being able to classify those fractures is kind of important, especially just using an AP radiograph. This is one of our papers that we published in 2018 on a fairly straightforward algorithm that you can use to classify those fractures that is purely based on pelvic radiographs. It's a very, very useful exercise to go through it, and it works by exclusion, looking at the iliopectineal and ilioischial lines and excluding what fractures can be involved to get to your final classification. Just to highlight everything that we discussed here, I want to show you how this works. We have this AP radiograph. We're going to look at the ilioischial line and ilioinguinal line. So ilioinguinal here is broken. Ilioischial is that line here, and it's broken here. So two lines are interrupted. It can be an associated both column. It could be a transverse, or it could be an anterior column, posterior hemitransverse, or it could be a T-type. Next step is I'm going to look at the weight-bearing portion here. You can see that this weight-bearing portion of the acetabulum is no longer attached to the constant fragment, and that makes it automatically an associated both column fracture without the need of any CT scan or any other advanced imaging. We'll still get them to understand the fracture, but with an AP radiograph, you can do most of that classification. You could see that this is the posterior column totally medialized, and this is the anterior column piece that's going to have to be brought back to the constant fragment. Those are the obturator oblique and iliac oblique views that confirm that diagnosis. You could see it particularly here. You see the spur sign here, which we just discussed, breach of the anterior column. And here, the anterior column on an iliac oblique, you normally see the posterior column here, but you can also guess that this weight-bearing portion is entirely contained with the anterior column portion of that fracture, making it an associated both column. Briefly, I want to talk about tools that I use. This is kind of my go-to. I use other stuff too, but that's the kind of the basic stuff. Youngbluth clamp, Weber clamp, pick sticker. I also love having a broken cannulated screwdriver, sharp, that allows me to get to do more percutaneous screws. So the reduction from anterior intrapelvic approach, this is a T-type fracture, but if you just focus on the transverse component, the clamp is positioned in this area to reconnect and give a vector of force that is orientated from medial to lateral, because it is a transverse fracture. So we're going to place a clamp from medial to lateral to reduce that fracture. You can also place a clamp, and I think I have a picture later in the slide that goes inside, applied to the transverse component, comes out of the stoppa, over the patient, over the iliac crest. So it comes inside here, comes out over and comes back in through a percutaneous incision on the ASIS and is positioned on the outer table. So this gives you a very forceful vector from medial to lateral. The clamp comes out and back in. And I think I have a picture later. There we go. No, that's still a fully inside clamp. But you can use a ball spike to help you push if you need to. The problem with these clamps is then they get in the way of anything that you may want to do. So what I like to do is once the clamp is in place, I'm actually going to leave the clamp on. And let me pause this for a second. You've seen me drill a hole in the constant fragment here. And I don't put a plate there. I just drill a hole in the good bone infrapectineal right in front of the sacrum. And it's a very small, fiddly area with lots of vessels. So you got to be a little careful with your retraction. But I drill a hole, I measure, it's usually about a 36, 34 screw. And then I bring a plate. Once I've measured, I put the screw through a 3 or 4 hole third tubular plate, and I put it out of the patient. It's sticking out, and then I bring the whole construct in, and now I have my hole pre-drilled, and I don't need to hold onto the plate or anything else, and I can fire my screw in there. And this is a very, very powerful, it's an antiglide fixation, because this transverse fracture usually needs an antiglide fixation. And it can be very powerful to actually reduce the final few millimeters that you require, but more importantly, get rid of your clamps. So then you have no more clamps in the way. You have a small plate, fragment specific, and you can neutralize with a larger plate. My go-to for posterior work through the Coker-Langenbeck, whether it's a posterior column, isolated, or a transverse fracture or a T-type, is to use a young Bluth, a 4.5 millimeter young Bluth clamp. And the reason for this is usually you will find that by just tightening this clamp on, it reduces the fracture. And if it doesn't, you have a very powerful instrument that can translate, distract, and move in most directions to reduce your fracture and keep it in place. An important point when you use the young Bluth, as you can see in this video, is always leave room for your plate. So at the beginning, when you start using those, you may have a great result, everything's reduced, but now you don't have a place to put your plate and secure your fixation. You have to take everything down. So when you drill your holes to pass your 4 or 5 screws, make sure you are leaving ample room for fixation of your posterior column. And then finally, how do you reduce an anterior column from the back? Well, you're going to have to very carefully place clamps through the great ascitic notch. And I like to use a Weber clamp, as shown here. It requires some practice pre-operatively. I would take a pelvic model before you start and look at where you're going to be and kind of the direction of your clamp through the notch, because you want your tine to reach the anterior column component so that you can reduce it from the Coker-Langenbeck approach. Once your clamp is on and you want to fire an anterior column screw, prone positioning is much easier on the prone patient when you do a transverse fracture. You not only have the advantage of not having the weight of the leg displace fracture when you're in a lateral decubitus position, but you also have the ability to get an inlet, which is in this plane, an inlet X-ray to get your anterior column screw, which is virtually impossible to get when the patient is in lateral decubitus. So if you want to fix the anterior column from the back, I recommend that you go prone, because you'll be able to get your X-rays. The only reason why you may not be able to do that is if you need to do a trochosteotomy, which kind of pushes you to be in a lateral position. These are the views used for a percutaneous anterior column screw, obturator oblique view on the left, and inlet view on the right. I like to overlap the superior and inferior pubic ramus to place those screws. You can place them obviously antegrade if you're prone, but if you're supine, you can do that antegrade. I'm going to show you a patient just to finish all this off and wrap everything around. I really want to emphasize on the importance of preparation and preoperative planning, especially when it comes to pelvic and acetabular fracture. This is a patient that fell from 80 feet, multiple other injuries. I'm not going to go through them, but ended up being cleared for his pelvis on day 2 or 3. You can see multiple fractures here. There's a fracture that extends on the ASIS, which is kind of a blessing because it allows us to do an ASIS osteotomy potentially. There's an acetabular fracture here. There's a pelvic ring injury here. Looks like there's a sacrum fracture. I'm going to show you the various views here, but essentially everything is broken everywhere. And the question is, the hard part here is, while one may have ideas, oh, I'm going to do this, I'm going to do that. The question is, what is your sequence of events so that you do not get blocked or you do not fix a malreduced fracture? It's, in my opinion, this is the toughest part of those cases is deciding the order of events and the surgical approaches. This takes hours and hours, especially at the beginning of one's career. And the importance of discussing amongst colleagues is key. But you see, as an example here, if you think that you're going to push on this to reduce that, well, you're wrong. This is the constant fragment. You're not going to push on this. This requires actually this fragment, the left anterior column fracture, to be medialized back onto that constant fragment. The other issue, so you can see there's a U-type or H-type sacral fracture. There's a comminution here. There's a dysmorphic sacrum, so we can't really fire transsacral screws here. So where do you start? Pros and cons. My feeling was if we start from the back here on the right side of the patient, and we do a coker, it is nearly 100% guaranteed, at least in my hands, that while fixing this, I'm going to have to fix this to the anterior column, and the anterior column is malreduced. So I'm going to shoot myself in the foot if I do anything that's posterior here on the right. And on the left, some difficulties are, how am I going to fix that fracture? There's displacement there. I need to do an extensile approach, and it's not the usual crescent. Crescent goes from top to bottom. Here it's from posterior to anterior. Very awkward position. So here is kind of the pros and cons of what the plan is. You could see here, if we do that from posterior, yes, we may get that posterior column back, but then we're going to shoot ourselves in the foot. I prefer to focus on this constant fragment here from the front, supine, internally rotate that anterior column, and focus on reattaching everything to that constant fragment. The order of event here will be to use exactly what I've described, which is a third tubular plate on that posterior column, and to use it as a reduction tool to the constant fragment, and to have a free hand access to that area that will then allow me to finish the work. We may use a Farabuff clamp to internally rotate that anterior column, and a ball spike pusher to reduce on that. And then here, highlighting what I expressed, you don't push on this constant fragment. We want a clamp that goes from inside to outside through a separate small incision to get on the outer table and correct that lateralized anterior column. This is that clamp. You could see it come in, out, and back in again. Then we did an extensile approach on a prone patient, and decided to bend and contour a third tubular plate 180 degree, like a hook, to get this, after putting a clamp, a young Bluth clamp here to reduce that fracture. We hooked the plate on the greater sciatic notch from through the notch and secured it to the constant weighing fragment. And to address this, unfortunately, we have a dysmorphic sacrum. So while the patient was prone, we did a tension band plate. You can see that picture, that AP radiograph that appears to show some decent reduction and at least an ability to start mobilizing this patient for the long term. Inlet and outlet, and then that is the end of my talk. I appreciate everyone listening. I hope that my attempts to make a topic that is seemingly simple has shown you the complexity of this topic, and hopefully also simplified some of the aspects for you to better grasp the nuances. Thanks a lot for listening, and I'm happy to take any questions.
Thank you, Cyril. Cyril, you can stop sharing. Yeah, thank you, Cyril, for this amazing presentation and absolutely stunning diagrams that you've been drawing. And we have had the pleasure to see those live now. Cyril, let's take you through some of the questions that have come up, and some of them I've picked based on what's trending, on what people search. And Cyril, what people love to, or they want to do, is percutaneous screws. Like, so how has been your learning curve? Because I worked in a pelvic unit for 3 years, and we opened the acetabulum and we just tried to put a posterior to anterior screw with image intensifier, and we found it even in an open situation how difficult it was. And how was your learning curve? Because now you do a lot of these percutaneous screws.
I mean, the learning curve is steep because it has so many components. It has the component, as we just highlighted, of understanding how to get a good X-ray. That's key. So a real in-depth understanding of those X-rays. Then it has the component of understanding the anatomy related to these X-rays. Where are the structures at risk? And then finally, it has the component of proprioception. So it's those three components, the three pillars: X-ray, anatomy, and proprioception, that are make this learning curve fairly steep. And the reason for this is, while you can study in the books for X-ray views, while you can study in the books for anatomy, nothing replaces the proprioceptive feel of I'm in the bone or I'm not in the bone. That's the first step of that third component. The second step of the proprioceptive feel, if I'm trying to summarize my thoughts here, is the ability to change direction of the wire when you're heading in the wrong direction. And that takes months or years to be able to say, oh, I'm heading a little posterior here, but I have a great starting point and it's looking good on this view. I don't want to change everything. I just want to change on one view. So how do you do this? This is practice. And I don't know if you guys, I recommend all the viewers to check out the Ortho Academy, my website, and it's free. I'm not making any money out of it. But I designed this very simple, cheap, reproducible model that is essentially a sawbone, $40, a piece of wood, $2, and a yoga mat, $11, that you can staple and go to your ORs on a wooden table with a fluoroscopy. And I can promise all my AO fellows that come to Denver, after a few weeks of practice on this model, those guys go back home to Argentina, to India, to Brazil, to wherever they're from, and they start doing this on their patients with incredible confidence and outcomes. And therefore, because not everyone has access to cadaveric specimen or high-level courses to practice, this is really the way forward to shorten your learning curve.
Thank you, Cyril, for that. And Cyril, when you start putting an AP screw starting from the pubis, right? One of the screws, an anterior column screw, you can start an entry from the pubis. And how difficult it is, because in males, you have the spermatic cord around. And do you think there's a risk for any of the injury to any of these structures? Because recently what happened is I saw a Russian surgeon who wants to put a nail through that.
Yes, I know them. Yeah. Yeah, I've seen those nails. There's also Curvifix. There's a lot of implants now, curved implants. I don't think that anything fancy is useful here. Just a straight screw is the way forward. If you PubMed or look at the maybe last 2 years, the Yellow Journal of the American Academy, we actually have a paper specifically on structures at risk for percutaneous pelvic and acetabular fracture. There's a video, and there's also the millimeters distances from every single areas in the pelvis where one may want to do a percutaneous fixation. So check that paper out. But essentially, when you're doing retrograde anterior column on the right, your starting point is kind of midline. Your incision is very distal. So I use a straight midline incision about 1 centimeter, because your starting point for the right and the left is the same. And as long as you start midline and you're starting distal, your spermatic cord is a little more lateral. It is a structure at risk, but if you're staying midline, you want your point to be very midline and very distal. That is the tip for a retrograde anterior column screw. And you want to be on bone to avoid, injuring structures.
Thank you, Cyril. Cyril, you have a lot of interest in artificial intelligence, right? So do you think there's a role for AI in picking some of these X-rays and making an accurate diagnosis? For example, you feed in a lot of X-rays with the right diagnosis, and do you think AI will help us give an accurate diagnosis, especially with these variety of fracture patterns?
So let me answer your question with a question, if you don't mind.
Sure, of course.
So the machine, so first of all, to answer your question, yes, of course, there's a lot of potential application, but my question is, why would that matter? So having a machine that tells me this is an associated both column actually removes from my mind the very important exercise of knowing what an associated both column is. And the fact that, well, associated both column, I need to lateralize everything. I need to fix everything to the constant fragment. And I know that there's no pieces of joint on that constant fragment. If the machine does that exercise for me, I will skip that crucial step in the understanding of the surgeon's perspective of how to reduce it, how to fix it. Where I think there's way more application is more machine learning than artificial intelligence. But I think a key part is going to be LC1 pelvic fractures. We still don't know what is stable, what is unstable. We do stresses, right? You may have seen some of our papers, the lateral stress radiograph. Some people do EUAs and the OR. But what are not over 150 cases, over 1 million cases that are fed to a machine? Can the machine predict, based on the fracture configuration, which of these are unstable, which of these are stable, so that I know, without having to do a test, whether I need to fix that or whether I need to treat this non-operatively? I think that's where the machine learning will come into play, and so is prediction of non-unions, for example. But this exercise requires a heavy lift of uploading data into that machine so that the machine can learn.
A lot of surgeons are interested in an acute total hip arthroplasty in elderly acetabular fractures. So you work in one of the finest trauma centers, the Ernest and Moore Trauma Center Level 1 in Denver. And how often do you do an acute hybrid total hip replacement in these elderly acetabular fractures?
So the answer is I've only done it once. And I don't recommend anyone doing it. And the reason for it is I don't see any benefit. I don't see any fracture that may, this is sorry, I'm going to step back here because I was going to be a little extreme. My opinion is that it is better to stage and to delay a total hip replacement. Doing a total hip replacement in an elderly patient is an invasive, aggressive procedure that carries a high risk of infection, high risk of dislocation, high risk of death, DVT, pulmonary embolus. There's a lot of risks that we're adding to a procedure that, in my opinion, has a way more predictable outcome if staged. And therefore, when I treat a 75-year-old, 80-year-old patient, osteoporotic, and we have a lot of these that break their acetabulum with the classic features of this is not going to do well, right? Marginal impaction, posterior wall, femoral head injury, all those stuff, comminution. We know we're not going to get that perfect. But what I know is that if I get the columns roughly back together and I don't place too many screws too close to the joint, because there's no point in doing that. I'm going to leave my screws, half a centimeters away from the joint. And that could also be just percutaneous, but it could also be open. Fixing the column, letting this patient weight bear as tolerated, seeing this patient in clinic. They may never need a hip replacement. You'd be surprised how few of them do. They may walk without pain. And if they do need a hip replacement at a year, you now have the ability to do a mini invasive anterior total hip replacement. No need to remove the hardware. The patient is optimized physically and physiologically, and you're having a way more predictable outcomes. My partner last week just did that. A patient, 300 pounds, dislocated, exploded acetabulum. He did a primary hip. Well, guess what? That got dislocated at day 2. And now we're dealing with a dislocation, potential infection, when this could have been avoided by just put things back together, let the patient get out of the hospital, see what happens later.
Thank you, Cyril. Thank you, Cyril. That's all the questions that we have for the session. Thank you for this very enlightening presentation. And I'm sure this is going to benefit a lot of people all over the world. So.
Thanks for the opportunity. Hello to everyone, and thanks for listening.
Bye-bye. Take care.